Oh, good evening. Hello. I'm just going to wait a few moments to see if we've got any more people joining, and then I'll add in my colleague. I'm Alison Campbell. I'm Fertility's Chief Scientific Officer. It's really nice to be with you tonight. Just got about half an hour, and we're going to talk through some embryo selection methods. So I'm going to add in my colleague. I've not done this for a while, so feeling a bit rusty. Just check. Here we are. Won't be a moment. So we're here at the end of National Fertility Awareness Week. So it's quite appropriate that we're here to talk about embryo selection. Hi, Nikoletta.
Hello, hi there, hi Alison.
Hi. Oh, better. You're vertical.
For now, fantastic. Good.
So I'll just introduce you. So I'm Alison Campbell. So I'm the Chief Scientific Officer of the Fertility Group, and this is Nikoletta. She is the consultant gynaecologist and subspecialist in reproductive medicine and surgery, and she's based at our clinic, Care Manchester. So welcome.
Thank you. It's nice to be in this live. This is the last Instagram live for the Fertility Awareness Week.
Yeah, and we've got lots of questions. So hopefully between us, we should be able to answer all the questions. We've got some that have been sent in already, and hopefully some of the audience will send some as we go. So, and between us, we've got the scientific knowledge and the medical side. So hopefully we'll manage them all. So do you want to get started first, Nikoletta, and just describe what PGTA is?
Sure, yes. So this is actually a very common question that we get from patients. So PGTA stands for pre-implantation genetic testing for aneuploidy, and this is really a test that we have to help us select embryos with the best potential to lead to a pregnancy and a live birth. The hope with IVF is that we create lots of embryos, but we know that lots of the embryos that couples create are not chromosomically normal, and they cannot lead to a healthy pregnancy and a healthy baby. So by identifying embryos that they actually chromosomically normal and they have a real potential to lead to a pregnancy and a live birth, means that we can concentrate our efforts in using those embryos with a stronger potential, so we can help our patients get to a baby sooner than later, reduce their chance of having failed cycles or pregnancy complications like miscarriage. So PGTA can help in this regard.
Perfect. So yes, and so we're going to talk quite a bit more about PGTA, but that's a really good background. So when our patients come to see us, we have to decide whether or not PGTA is recommended for them, because it's not for everybody, is it, Nikoletta? So do you want to tell us how we would decide which patients to talk about PGTA to?
Yeah, so in practice, PGTA can happen in all IVF cycles, so it could potentially happen in all patients if they want it. But the patients who most probably will benefit more from it are patients who are more likely to create abnormal aneuploid embryos. So we see that this is more likely to happen as we women, we get older. So couples where the female partner is older than 35 might benefit from it, as embryos created after the age of 35 are more likely to have chromosome abnormalities, and choosing the embryos with the best potential in that age group can help them reach to a baby sooner. Other groups that might also benefit are couples who have experienced a number of miscarriages or early pregnancy losses. A big reason why a miscarriage might happen has to do with an embryo aneuploidy, which means embryos with the wrong number of chromosomes. So again, PGTA, where we can help identify embryos with the right chromosome number, can help reduce the risk of miscarriage. Another patient group where I recommend PGTA are couples who have experienced a number of failed IVF cycles. Again, a big reason why IVF might not work are actually embryos with the wrong number of chromosomes. So again, PGT-A can help in that group as well. So these are really the three main groups where PGT-A can be helpful, but of course can be applied in other scenarios as well.
Yeah, great. So I've just seen some questions coming in. So I'll just talk a little bit about the embryo, the human embryo, and my passion. And so when we develop embryos for IVF patients in our laboratories, we grow them to the blastocyst stage. So this is generally when the embryo has up to 200 cells, so lots and lots of cells. And the way we can test for this aneuploidy, which is as Nikoletta described, it's this incorrect number of chromosomes, incorrect copy number, because we should have 2 copies of each chromosome, effectively one from the egg, one from the sperm, so one from each parent, genetic parent. And if the number's wrong, so we might have 3 copies of one chromosome or 1 copy of one chromosome. If that's incorrect, that's what we call the aneuploidy, and that's really quite bad news, because most embryos that have this incorrect copy number, so the aneuploidy, they won't implant. Some embryos with irregularities in the chromosome copy number can implant, but they would result in a miscarriage. And very rarely they could result in a child with an aneuploid condition, such as Down syndrome or Edwards-Patau syndrome. So in the laboratory, what we can do to test for the aneuploidy, so PGT-A, is to remove a few cells from this blastocyst stage embryo. And they can spare a few cells. They have got plenty and they can regenerate. So it's very effective embryo biopsy procedure. So we'll take a few of the cells and send them off to the genetics lab. So normally we would take 5 or 6 cells, and then we'll get the result back from the laboratory, from the genetics laboratory, within a week or two, and they'll tell us which embryo has the correct copy number, and they're the embryos that we will prioritize. So sometimes we'll get a result which says the embryo seems to be, according to the biopsy, mosaic. So that means it has, from these 5 or 7 cells that we've taken, some of them indicate that the copy number is correct, and some of them indicate that it's not. So from that, the likelihood is that the embryo itself has a mixture of aneuploid and euploid, which is the opposite of aneuploid, the correct copy number, a mixture of aneuploid and euploid cells. So let's talk a little bit about what we would do then, Nikoletta, if we get this result and it's mosaic. So we've got a mixture of cells.
Yeah, so I call these embryos a gray zone embryos because they're not 100% normal, they're not euploid, but they're not 100% abnormal. They're somewhere in the middle. So even though mosaicism is something that has always existed, I think we see it now more frequently because the technology starts to allow us to detect it. So, and because it's something relatively new, research and long-term data is ongoing. But when we have a mosaic embryo, whether we use it or not will depend on a detailed assessment of the level of mosaicism and also expert input from our geneticists that we have here in-house. So we will assess whether this mosaic embryo is a low-level mosaic embryo, which means that the majority of cells are normal and only a minority of them which might have chromosomal abnormalities, as well as the type of chromosome problem present. And the data that we have so far is that even though low-level mosaic embryos are not as strong as normal euploid embryos to implant and lead to a pregnancy and might have a slightly higher risk of miscarriage, all the data that we have from pregnancies that happen following the transfer of mosaic embryos is that babies born had no obvious abnormalities. So it is reassuring to know that. But of course, whether we transfer a mosaic embryo or not will depend on the data we get from the lab and testing from our genetic input, but also on patient preferences as well. And it will happen after a detailed discussion to understand patient values and preferences and how they want to proceed with their fertility treatment.
Great. And we just had a message live from one of our listeners, watchers, saying that they have a mosaic embryo on ice, so in one of our tanks, frozen, and they're wondering whether it's better to have that transferred or to come and have another treatment cycle and save that as a last resort. And I guess from what you said, then that's a decision that needs to be taken carefully and together with the consultant, have a review appointment and try and understand the level of mosaicism, maybe which chromosomes are affected, and then we can talk to the genetic counsellor and make a decision, because we do know that many mosaic embryos result in great success and euploid babies, so normal chromosomally balanced babies. So it is a difficult decision, but hopefully some of the literature, the publications and the genetic counselling support we can reassure.
Certainly, yeah.
There's another message that's just come in saying that this person's had fertility issues for 8 years and has been told there's nothing wrong. So what would we recommend? What IVF package would be recommended for them?
So this is a frustrating but a common scenario, unfortunately. We call it unexplained infertility, when all tests come back with normal results, but still a pregnancy doesn't follow. I don't have all the information I need to be able to give you the right advice, as I need to know a bit more about you, your circumstances, your health, your age, and your partner's details. So it's difficult for me to say at this stage what will work best for you. And we always strive to understand our patients, their circumstances, so we can create a personalized treatment plan. So I will say, just book an appointment with us and we'll be happy to help.
Great. So if I've got a few quick fire questions, which I think I'll fire at you, Nikoletta, and then we can move on to talking about Caremaps, which is another method of embryo selection. So can the biopsy harm my embryos? Well, I think I covered that. I've never known a biopsy harm an embryo. I think we do probably cite it as a risk of the procedure because it's like a surgical procedure on an embryo, but in my experience, I've never known that happen. What causes this aneuploidy?
That's a good question.
It's not a quick answer, but try.
Yes, that's right. So problems in embryos' chromosomes can either come from the parents. So if the parents have some chromosome abnormalities themselves, they can pass them on to their embryos and babies. In that scenario, a different type of testing called PGT SR, which stands for structural rearrangements, can help to identify embryos with their right structural component of the chromosomes. But the commonest reason why embryo aneuploidy or chromosome abnormalities in the embryos arise are random events that happen at the time when the egg and sperm fuse to create an embryo. And this is when, by mistake, an extra chromosome might be passed on to the embryo or a chromosome might go missing. Most of the times, these problems comes from the egg rather than from the sperm, and that has to do with the difference in women's and men biology. It can then potentially result to embryo aneuploidy and difficulties in conceiving, like we discussed.
Great, that's great.
PGT can help.
Yeah. Yes. And we do have technology now that helps us identify if it is a parental origin, if it has come from one of the providers of the egg or the sperm. We can identify where that's come from, which is the latest technology, which is really exciting and helpful. So what about this question here was sent in before? It says, my father has haemophilia. Could PGTA identify if any of my embryos are affected?
Yeah, so that's a good question. So the short answer is that in this scenario, you need PGTM or PGTA for monogenic disease. So hemophilia is a genetic condition where there's some gene changes linked to factors that play a role in our blood clotting. And specifically in hemophilia, these gene changes are based in chromosome X. So if we imagine a person like a library, then our chromosomes are like the books in the library, and we need to have 46 chromosomes arranged in 23 pairs, and then the chapters in each book are called our genes. So in case of hemophilia, a person who has hemophilia has still the right number of chromosomes, the right number of books, where if we do PGTA, we'll still identify that it's likely that, embryos resulting will still have the right number of chromosomes, or won't be necessarily affected by the hemophilia, but there will be changes in the chapter into the book. So for that reason, we need to do PGTM to help identify embryos that carry the right gene chains. So this is something we can do here in care, and we have helped lots of couples with genetic disease to have unaffected embryos through this process. So we have lots of experience in doing that. PGTM can be combined with PGTA to help not only identify embryos with the right gene changes, but also with the right chromosome numbers.
Yeah, great. And it can, so we've done that for many different genetic conditions, not just haemophilia. So an amazing technology. It's helped lots of families.
Mm-hmm.
Great. So could we test previously frozen embryos?
Mm-hmm. Yes, so this can be done. Of course, this will involve warming up the embryo, biopsying it, refreezing it to wait for the results to come back, and then planning for a frozen embryo replacement. And again, this is something we do frequently. So our lab here in Manchester, I'm sure in other things as well, have lots of experience in doing so. I'm sure that Alison, you know more about that. Yes, and. Mm-hmm.
Yes, no. So we have got we're very experienced at embryo vitrifications. That's the freezing, and the warming, and the biopsy, and a re-vitrification. So a refreeze whilst we wait for the results. And that sometimes patients request that because maybe the embryo has been frozen a long time and the technology wasn't available then when they had the treatment, or they've just understood more about the technique. They weren't sure at the time and now they've decided to go for it, or they just want to move faster, because one of the main benefits from PGTA is that we can select the best embryo from a group. So they might have a number in the freezer, and unless we do the PGTA, we will just choose the best one that we think, and we can't see the chromosomes copy number without this technology. So the embryologist will just choose the one that looks to be the best, and it isn't always the one that's got the correct copy number and is the euploid one. So it saves time and cost, emotional and financial cost, because just going through, say, 5 embryos one by one, and if only one of them happened to be euploid, we may get to that one last. Whereas if we do the PGTA, we can get that one first time. So it really speeds up the process and reduces the amount of treatment cycles and transfers that embryos, that the patients need to have. So it is it's very successful. So we move on to Caremaps. So this is another method that we use at Care Fertility to choose the best embryo from a group of embryos generally, because again, we want to choose the best one first time. We want to get our patients their baby as soon as possible and minimize the number of transfer procedures. So when anybody goes under an IVF cycle, we try and stimulate the ovaries in order to collect a good number of eggs, so that we can have more embryos to choose from. And Caremaps is a technology based on time-lapse imaging. So in our incubators, our specialized time-lapse incubators called embryoscopes, we take photographs of the developing embryos right from the beginning, right from the time of insemination, where we do ICSI or IVF, through to fertilization, and then for subsequent days. So we're monitoring them continuously without disturbing them. And that's one of the important features of time-lapse imaging. We don't need to take the embryos out of the incubator in order to look how they're getting on, how they fertilized and how they're developing. So we've been using this technology for about a decade. So we were the first IVF clinics in the UK to introduce time-lapse imaging back in 2012, I think. And so as we're a big group of clinics and we're all using these embryoscopes and we're all collecting this important information about how embryos are developing, we've gathered a lot of confidence and evidence in this technology. So we've built our own algorithms. So I don't want this to be a maths lesson, but it's a model which, based on all this information, helps us select the best embryo. So keeping it really simple as we can, if we imagine over these years, we've transferred a lot of embryos, and some of them have made babies and some of them haven't. So we've been able to compare these images that we've collected and the timings that embryos reach each cell stage, so the time they become a blastocyst, the time that they fertilize, and everything in between, the time that they have 8 cells or 12 cells. So based on all this data, we found significant differences in the patterns of behavior, the patterns of development between those embryos that have resulted in a baby and the ones that have not. So we've built these algorithms to help us choose the best embryos based on these developmental patterns. And more than that, really, we've got a scoring scheme. So each embryo that we apply this model or algorithm to will give us a score. And that score tells us what the chance of having a baby will be with that particular embryo. So we choose the embryo from a group. Not everybody has a group of embryos, but nevertheless, we'll have a score for each embryo that goes through our Caremaps, and we'll choose the embryo with the highest score, and we'll be able to tell our patients their actual chance of having a baby with each of their embryos that we've applied Caremaps to. And then we send them, if they want to see it, and mostly they do, the video of their developing embryo and the one that we've transferred, the best one. So there was a message that just came up saying that we've got a patient watching who is having Caremaps at the moment, and they want to know, will there be regular updates? There could be regular updates, but it's not really going to help until we get to the blastocyst stage, because that's when we apply our Caremaps algorithm, and that's when we find out the score and the chance of a baby. So probably sit tight for a few days, and we'll hopefully have some good news for that patient. So how do you find Caremaps? Because you're relatively new to it, I guess, and
Yes.
I've been living with it for 10 years. So
Right, yes, obviously it was really nice to hear all about Caremaps from you, being the brain behind it. So yeah, no, I think Caremaps do provide lots of additional information to help us and patients with embryo selection. And it can be combined with PGT as well. I think this is a very useful tool that we have here for our care patients, and certainly something I recommend. It does help with discrimination to identify the embryos with a stronger potential and use it sooner. So certainly something that's helpful.
yeah, and actually we didn't mention this, but with all our PGTA treatments, we incorporate Caremaps. And really this is for 2 reasons. The first reason is, if for any reason we don't proceed with the biopsy and the PGTA testing, we've still got information from Caremaps because we've monitored the embryos and we can see how they're developing. So if they stopped developing, we'd still get some knowledge about why, maybe understanding why this has happened, and certainly seeing when the development stopped. And also because some patients have several embryos that have the right copy number, so several euploid embryos, and we then use Caremaps to distinguish between them, because our data shows that they work quite synergistically, they work well together, so we can choose the best of the best. So that's really effective too. There's a question here. Can I have PGTA or Caremaps, for that matter, on the NHS?
So that's a good question. And of course, we do see NHS patients here in care quite a lot. And we want them to be able to have access to this additional technology we can offer to maximize the chances of success. So yes, this is something that you could have in addition to your NHS cycle of treatment. Unfortunately, this is not covered from NHS. It will be a matter of self-funding for it. But if it means that it can make your treatment more successful, help you to get to a baby sooner, that might be something worth considering. So definitely something we will be exploring on a case-by-case basis.
Yeah, that's great. Yes, and so same with Caremaps and PGTA, and our NHS patients can elect to add on or supplement their treatment by buying these extra offerings to improve their chances. Great. What are the statistics for live birth from PGTA testing?
Mm-hmm. So the data we have now is that if we have a euploid embryo, this will give you a 60% chance of pregnancy and a live birth. And data shows that if a couple has 3 euploid embryos, there's almost a 90% chance of having a baby using them. So it actually gives you a greater level of certainty that you'll be able to reach to a pregnancy and a baby using euploid embryos.
Yeah, great. Well, let's have a couple. We've nearly run out of time, Nikoletta. It's gone quickly. Let's have a couple of questions that have come in. One patient's asking, it's a bit of a general question, but I think it's an interesting one. How long approximately would it take from inquiring at Care Fertility to make an appointment for a consultation to an embryo transfer?
Mm-hmm. Yeah, so well, we don't have a waiting list here in our care clinics. So we are happy to see patients very quickly, and we're efficient in arranging initial investigations and discussions and treatment. Difficult for me to say a specific kind of time frame because every circumstance might be slightly different, but usually within 6 to 8 weeks, one can actually have their embryo transfer as long as everything is straightforward.
Yeah, we've had that question twice. I think it is an interesting one because people sometimes have no perception of how long the whole thing takes. So there's the consultation, and depending on what tests and investigations have gone before, it might be we don't need to do any further. It may be they're fairly recent and we don't need to do that. But generally we'd do some screening, and then we'd do a protocol, a sort of medication prescription, and some training how to do that, and then get started. And a couple of monitoring episodes, some ultrasound monitoring during the stimulation while we're trying to get the follicles to grow, a couple of visits to the clinic, and then once the follicles on the ovaries getting to the right size, we give a final injection, and then see the woman 2 days later for the egg retrieval. And then in the laboratory, it's less than a week where we're working the magic in the laboratory, and then embryo transfer. So yeah, it can be fairly fast flowing if everything's going to plan. Mm-hmm. Anything else before we go? Is there anything else you want that we might have missed, Nikoletta?
No, I think quite interesting questions, and we probably covered quite a few already. Significant ground with embryo selection options we have.
Yeah. Well, there's one good question here, just a last one, if you don't mind. With a normal embryo from PGTA, so a euploid embryo from PGTA, is that more likely to be successful and to implant than an embryo that is untested?
Yes, that's right. And that is the reason why we'll be recommending PGTA. When we have an untested embryo, we can judge its potential to lead to a pregnancy and a live birth based on how it grows in the lab, and how it develops and divides, and when it achieves certain milestones in its development. So am I right, Alison, in saying that traditionally the way of selecting embryos included just extended culture, where the embryos are left in an incubator after they initially checked, and then assessed again after 5 days, and see which ones managed to reach to a blastocyst. But in that process, we were missing lots of information about what happened beforehand, which can help with identifying the stronger embryo. So adding Caremaps to that can help with improving the sensitivity in choosing an embryo that can lead to a live birth, and potentially, am I fair to say that if we have a top blastocyst marked in a Caremap, that might give a 40 to 50% chance of a pregnancy. But if we have a euploid embryo, which means an embryo which has managed to reach the blastocyst stage, look morphologically normal, but also has the right chromosome numbers, this can raise your chance of a pregnancy to 60%. So having this additional information can help give you more assurance of the outcome of your embryo transfer.
Yep, that's perfect. And yeah, and I think that the important point really is that everything needs to be individualized. Unfortunately for us women, the older we get, the more chance we have of aneuploidy in our eggs, so the irregular number of chromosomes. So if we're 25 years old, the chances are that the aneuploidy rate will be quite low. It's still there, but if we're 35, it's higher, and if we're 45, it's really high. Most of our eggs will be aneuploid. So in terms of PGTA, the older we get, the more important and the more helpful it is. And that's the most important point, I think. But also there are other things that make PGTA very important for certain patients, even if they're young, if they've had recurrent miscarriage or they've been trying for a very long time and we don't have many answers. PGTA can be really helpful there too. So I'd just like to tie this up. I've got one last message, just not really a question, it's a message, to say that I think it's an NHS patient, because it came up when we were talking about NHS and adding on extra things. They paid for Caremaps and it was really well worth it. They have a 4-month-old baby boy. Oh, so that's wonderful news. So I think we'll say goodnight on that lovely point, and we hopefully be back soon, and I really hope everybody's enjoyed it and have a wonderful weekend. And we're here if you need us, send any questions through to us via email or ring our inquiry line, and we'll be able to help you. So good night, everybody.
Good night from me too.
Thank you. Thanks, Nikoletta. Good night. Have a lovely weekend.
Bye. You too.
Bye. Bye.